The next defect is Ebstein's anomaly, which is a disease of the tricuspid valve occurring in less than 1% of congenital heart diseases. The pathology of the disease involves displacement of the septal and the posterior leaflet of the tricuspid valve into the right ventricular cavity, so that a part of the RV is now becoming part of the right atrium. We call it atrialization of the right ventricle. There is functional hypoplasia of the RV, where the cavity is becoming smaller. This abnormal valve is severely regurgitant, and this results in dilated right atrium. There is usually a large AST with a right to left shunt in all these patients. The right ventricular free wall is often dilated and thin. These patients are always suffering from Wolff-Parkinson-White pre-excitation, and predisposes the patient to SVT. A common association with this pathology is pulmonary stenosis or pulmonary atresia, sometimes TOF and BSD. Clinically, these patients present with cyanosis and congestive heart failure since the first few days of life in severe cases. By time, pulmonary vascular resistance may decrease, which allows a more pulmonary flow and decrease of the severity of symptoms. Milder cases may just complain of dyspnea, fatigue, cyanosis, and palpitation on exertion. There may be a history of supraventricular tachycardia. By physical examination, there is mild to severe cyanosis according to the condition. In older children, there may be clubbing. By examination, there is widely split second sound, a pansystolic murmur on the tricuspid area for the tricuspid reverse, and there may be also a mid-diastolic murmur at the same location for a relative mitral tricuspid stenosis because of the increased flow across the tricuspid valve. Hepatomegaly is usually present. ECG shows right bundle branch block and right atrial hypertrophy in most cases. Sometimes we can show first-degree heart block. Wolff-Parkinson-White pattern of the pre-excitation can be elicited. Sometimes a patient may present by SVT, and this can be elicited by ECG. Chest X-ray may not show changes in mild cases. However, in severe cases, there is extreme cardiomegaly due to hugely dilated right atrium, and in such case, usually there is decreased pulmonary vascular markings. Echocardiography is the procedure of choice for the diagnosis and assessment of Ebstein anomaly. Cardiac catheterization is not needed. If these patients are left untreated, some severe cases may die in the neonatal period. 30% of patients die by the age of 10 years from congestive heart failure. Patients with less severe anomaly may be asymptomatic or mildly symptomatic. However, by time, hemodynamic deterioration increases the cyanosis, congestive heart failure symptoms, and LV dysfunction will develop later in life. Sometimes there are attacks of supraventricular tachycardia associated with WPWP excitation in 15 to 20% of cases. Sudden unexpected deaths may occur due to arrhythmias. Medical management of these cases includes the following. First, in severe cases, may need mechanical ventilation, prostaglandin E1 infusion, inotropes, correction of metabolic acidosis prior to surgical emergency procedure. Asymptomatic cases may just need regular follow-ups. If congestive heart failure manifestations develop, anti-failure, anticongestive medications can be added. Acute episodes of supraventricular tachycardia may need urgent intervention with adenosine. Prophylactic beta blockers can be added to prevent recurrence. Urgent surgical intervention may be indicated in critically ill neonates who are showing symptoms within the first few days of life. Surgical intervention also may be indicated in cases with progressive cyanosis or congestive heart failure manifestations, right ventricular outflow tract obstruction by the redundant tricuspid valve tissue. If there is a history of paradoxical embolization due to the right to left shunt across the interatrial septum, septal defect, and also in cases of repeated life-threatening arrhythmias. Surgical procedures include palliative procedures for critically ill neonates with failure of medical treatment to avoid death. This includes VT shunt and atrial septectomy when there is obstructive lesions between the right ventricular cavity and the pulmonary artery or a stenotic tricuspid valve. We can directly proceed to a classic Glenn if the RV cavity is not sufficient and the child is severely cyanotic. Definitive procedure includes either biventricular repair if the patient has a good sized right ventricle and with a good function, or we can perform a univentricular repair when the RV size is not adequate following a bidirectional Glenn operation which was done earlier in life. Other procedures can be done for patients with recurrent supraventricular tachycardia as radiofrequency ablation of accessory pathways.